time I get to spend with you guys and talk about all sorts of plastic surgery topics and of course answer all of your plastic surgery questions. And you know that it's coming from a reliable source because I am a double board certified plastic surgeon, Duke trained, Ivy League educated, with over 12 years of experience now, hence all the gray, yeah, and thousands of cases under my belt. And so today, one of our followers wrote to me after our last live, and she's like, "Hey, Dr. Earle, really love you talked about this, and that's great. I love it. I love it when you guys interact. When you're writing your comments, when you send me DMs, and you let me know like, hey, please answer this question, or let's talk about this in your next live. So like, if you have any suggestions or other questions that we don't get to, please go ahead and reach out to us. Okay." All right, but today we're going to talk, initially about lipo and BBL complications, okay? And then, of course, once we're done with this, I'm happy to answer any questions that you may have. But, it's always important to talk about complications as well, right? Not only the benefits of everything that we do, but, of course, every surgery that we do carries some degree of risk, okay? And so it is, very important to talk about the complications and everything that can be done to try to minimize them. However, everyone must know and must be aware that you can never have a 0% complication rate, okay? That's just not possible if you're going to go undergo surgery for whatever reason, whatever procedure, and that's whether it's plastic surgery, pediatric surgery, cardiac surgery, or any other surgery, right? Think of it like driving a car, right? The only way to guarantee a 0% chance that you're not going to get in a crash is to not drive a car at all, right? But if you're driving, doesn't matter how careful, how excellent a driver you are, there is a possibility that you can get into an accident because there are so many factors that are outside of your control, right? So, same thing with surgery. There are many factors that are outside a surgeon's control, and therefore the complication rate can never be 0, but we can try to do everything that we can to minimize it, to bring it as low as possible, okay? All right, so what are some of the possible complications of liposuction and BBL, okay? So really, when you do a BBL, as everybody knows, it's a combination of the liposuction and then the fat transfer. So BBL by definition involves liposuction, and then of course you can do liposuction, liposculpture, HD lipo, ab-etch, and you can do that on its own without any fat transfer, okay? So the first complication is the one that's most related to the BBL portion or the fat transfer portion of the procedure, which is what's called a fat embolism. Okay, what does that mean? It means that fat gets into a large vessel, typically a large vein, and from there it travels inside the vein all the way to the heart and lungs. Okay, so that's what's called a fat embolism. And when a lot of fat does this, it causes serious problems. It can even cause, basically pulmonary collapse, meaning you're not able to put in oxygen, take out CO2. Basically, the lungs get all clogged up. They're not able to function, and then the patient can potentially pass away. And sometimes this can happen very, very quickly, right? And so this is what all the hoopla about BBLs has been about. And that's why at one point in time, back in 2017, it was considered one of the most dangerous cosmetic surgeries out there. However, that is not the case today, okay, 2025. All right, so back in 2017, the mortality rate for BBL because of fat embolism was about 1 in 3,000. That is no longer true. If anybody tells you that, it's because their data is completely outdated, or they're just trying to scare you, trying to scare you, okay? Now the mortality rate for a BBL is about 1 in 15,000 or less, which is the same as pretty much any other cosmetic procedure, for example, a tummy tuck, okay? Why is that? What has changed? Well, what has changed is something that I've been talking about forever. So you guys have been following me for multiple years, know that I've been talking about ultrasound-guided BBL since 2019. I'm one of the first people to start doing this, one of the pioneers in this technique. And I've done over 2,000 ultrasound-guided BBLs now to date. and I've had 0 fat embolism, 0 mortality from that, okay? Why? Because I'm using the ultrasound imaging so that now I can actually see exactly where I'm placing the fat. I'm placing it in that safe zone, which is between the skin and the muscle, and we're avoiding the danger zone, which is deep or into or deep to the muscle, okay? So that's one of the things that people talk about a lot, and there's definitely a way to minimize that risk, and that is to use ultrasound imaging. And again, not only that, but you want to go to someone who has a lot of experience doing this, okay? Because experience in this technique counts, okay? So someone who's gone through the training and has the experience as to how to perform an ultrasound-guided BBL or fat transfer, okay? So that's how we decrease the risk for that. And so far, the incidence of fat embolism here at Pure Plastic Surgery has been 0. Okay? All right. So, next thing. So now this fat embolism is different than a blood clot. And people get these confused all the time because there's something called a fat embolism and there's something that's called a pulmonary embolism or PE. These are not the same thing. Okay? A PE, which is a pulmonary embolism, or a DVT, which stands for deep vein thrombosis, which is a blood clot in the lower extremities in your legs, these are due to blood clots, okay? This is not something that the surgeon does. This is something that can happen to the patient, okay? But it's not a technical thing like injuring a vessel and then having a fat embolism, okay? So a blood clot is not controlled by the surgeon. This is actually more controlled by the patient. Because the way to minimize the risk of a blood clot is to properly wear your compression device. We use the VenaPro here. It's a compression device that you wear in the legs to keep the circulation moving, and we provide that for all of our patients. And you have to wear that for the first 2 weeks. Super important. You wear it for the first 2 weeks, especially anytime you're resting, anytime you're sleeping. If you're from out of town, when you go back home on the plane, you have to wear it in the plane, okay? Super important. All right, and so that's one way to minimize that risk. And then the other way, of course, is you're walking, right? You can't be sitting around, laying around all day after surgery. You have to be up, you have to be mobile, you have to walk. Our recommendation is that you're walking at least 10 minutes every hour while awake, okay? But if you have a patient that's non-compliant, right? They decide not to wear their VenaPro, they decide not to do their walking, they decide to go, say, for example, on a 5-hour drive without stopping, without walking, without wearing their VenaPro, well, then the risk of something like this goes way up, okay? So this is a patient-controlled issue. So you want to decrease your risk of blood clots, you have to be compliant. You have to wear your VenaPro device. You have to do your walking, okay? For other types of surgeries, say, for example, mommy makeovers, tummy tucks, and things like that, for that type of surgery, sometimes you can even add something to this, which is a blood thinner called Lovenox, okay? I don't typically use blood thinners for lipo and BBL cases because I also worry about this, which we're going to talk about here in a second, right? And of course, blood thinners increase your risk of bleeding. So I try to decrease the risk of blood clots with the use of the VenaPro device and encouraging the patient to walk, okay? All right. Next, of course, infection that can happen with any surgery. So how do we decrease that risk? Well, we have a lot of things that we do instead of in our technique. So we put antibiotics in the fat before we transfer. Actually, even before that, we give the patients some IV antibiotics right before starting the case. We put antibiotics in the fat before transfer. We also use betadine to prep the patient and to prep the cannulas before each insertion of the cannula. It's like an iodine solution. We have UV lights in the OR that kills just about everything from bacteria to viruses, whatever you can think of. And so we use all of that, and we give the patients 1 week of antibiotics after surgery to try to minimize that risk, okay? And I am happy to say that for BBL, we've been able to bring this risk of infection down to 1.5%. Extremely low for BBL, much lower than the national standard. The national standard is somewhere in the range of like 6 to 10%, okay? This is ours because of everything that we do to try to minimize that risk, okay? You know what's been happening lately though, regarding infection? And please don't do this, ladies, is that we have people that are going home and they're going to see massage therapists that are not our massage therapists, and their massage therapists are opening up their incisions. And then all of a sudden, it's 2 weeks after surgery, and they're calling us because the area where the incision was opened up by their massage therapist at home is now red and swollen and angry looking. Well, that's not an infection that happened at surgery time. That's an infection that happened secondarily at the time of the massage therapist at home opening the incision in a non-sterile manner. Ladies, don't do that. Please don't do that. Okay? All right. What's next? Lidocaine toxicity. What is that? Well, if you're doing, this is why I don't like to do this procedure awake. Okay? If you're doing the procedure awake, that means you have to give the patient something to numb them up. That something that you give them is called lidocaine. Well, guess what? If you give a patient too much lidocaine, they can develop something called lidocaine toxicity, which means that can affect their nervous system, i.e. seizures, or their cardiovascular system, heart attack, heart stop. Okay? So that's why I eliminate, this is the one thing that I do eliminate completely. For my surgeries, I can actually say that there's a 0% risk of lidocaine toxicity. And why is that? Because I don't use any lidocaine. I don't use lidocaine at all because I do my surgeries under general anesthesia. And so when you do your surgery under general anesthesia, you don't have to add lidocaine to the tumescent solution. You just add the saline solution with the epinephrine, which helps, clamp up the blood vessels so there's less bleeding. And that's it. No lidocaine whatsoever. So if there's zero lidocaine, there's zero chance of lidocaine toxicity, which is why I'm a huge advocate for doing these procedures under general anesthesia, and why I actually think it is safer to do them under general anesthesia than to do them awake, awake lipo, awake BBL under local. It's actually safer in my eyes to do it under general anesthesia. All right, next, bleeding. Bleeding can happen with any surgery, and you never know who's going to bleed. Some people are going to bleed, some are not. Okay, there's genetic factors involved, all sorts of things are involved that are outside the surgeon's control. And remember that liposuction is quote unquote a blind procedure, right? You're putting this cannula inside and you're going in there and you're removing the fat, and it's not like an open procedure like a tummy tuck where I can actually see and cauterize every single vessel that I'm coming across, right? So lidocaine is a closed procedure, it's a blind procedure, so you have less control over bleeding. So how do you try to decrease the risk of needing a blood transfusion? Well, first of all, you make sure that you start off at a good place. So everyone's hemoglobin level needs to be 12 or higher. And then we have a device called the Cell Saver. So the Cell Saver is a device where once we do the liposuction, of course, when you do lipo, you remove fat and fluid and blood. You then separate the fat from the fluid and the blood. And then that fluid blood, you pass it through the Cell Saver, multiple filters where it basically separates out the patient's blood from absolutely everything else. And then you're able to give that blood back to the patient. And so overall, you have less bleeding, and the patient then does better, recovers quicker, and everything else. So we do a Cell Saver for all of our major liposuction cases here at Pure Plastic Surgery. Okay? And then, well, this one, let me skip down to the last one, which is a bit more severe. That's organ perforation. Again, remember, liposuction is something that is done blindly with a long cannula. So, it really is something that shouldn't happen, right? If you go to a surgeon that knows what they're doing, that has experience with this procedure, there should not be an organ perforation. That is definitely on the surgeon if that happens, okay? So definitely surgical technique. Now, if you have any questions, like maybe you think you have a hernia. If you think you have a hernia, especially a large hernia, then we have to make sure that we do some imaging. Make sure that whether it's there or if it's not, and if it is there, then we gotta fix the hernia before your liposuction procedure. So that is something where the patient needs to be aware of this, right? If you feel that you have a hernia in your belly, especially in that central belly region, you gotta tell the surgeon, okay? And then we can investigate it, we can do some imaging, and if it's a significant hernia, we may even need to fix it before your liposuction procedure. Now, if it's like a very small, belly button hernia, like a 1 centimeter, very small belly button hernia, then typically that's something that we can work around and not a big deal. But if it's anything bigger than that, then it needs to be taken care of before your liposuction procedure. Okay? And then last but not least, is actually probably the most common thing that can happen, which is not serious at all. It's seroma, is just fluid accumulating within the tissues that sometimes gets trapped in there and you can't get it out with compression or with a massage. And so the treatment for that is just placing a little needle into the area, sucking out the fluid, and then typically you're done. Sometimes you may have to do it twice, maybe 3 times, but after that everything is good as long as you continue with your massages and your compression. Okay? All right. Happy to answer any questions.
We have a lot.
All right, let's do it. And I really hope the person that wrote to me is actually watching, because I did this because of her. So I don't know. Hopefully she's out there somewhere.
Is permanent loss of sensation to nipples after breast augmentation and abdomen after tummy tuck? So is permanent the loss of sensation?
Okay. So with a straight breast augmentation, meaning no lift, a permanent loss of nipple sensation is very rare. I would say that's pretty rare. It is more common when you're doing either a breast reduction or a lift, especially if you're using that anchor type pattern, where you may have some permanent loss of sensation. I'm not saying complete loss, but some loss of sensation. That is more common with those procedures. But for a straight breast augmentation, it's pretty rare. Now for the tummy tuck, it is not unusual to sometimes have some loss of sensation, especially near the incision, near that central lower belly area. Sometimes you can have some loss of sensation there. Typically, it does get better over the course of the first year, but in some patients, it may not come back completely.
What exercise are safe to start with 6 weeks after BBL?
Great question. So it's good because you know that at 6 weeks is when you can start exercise. So before that, you shouldn't be doing any strenuous activity or heavy lifting or any big exercises. But at 6 weeks is when you can start. What I always tell my patients is that you want to kind of start slow, ramp yourself up over a couple of weeks. Remember, you've had a big surgery. You've been kind of out of it for 6 weeks. So don't try to go in there the first day and just kind of do everything that you can. Just start slow, ramp yourself up. But what we do recommend is what's called weight-based exercises, right? So exercises that are going to either use your own body weight or external weights. That's what we do recommend. Squats are actually a great exercise to do after BBL. It really helps continue to shape and round things out. So I do recommend squats. And what I don't recommend are kind of long cardio type exercises. That's what we don't recommend. So you want to do either weight-based exercise and then also plus minus some high intensity interval training if you want to do that.
Do you use ultrasound guidance for BBLs to avoid fat embolism?
Exactly. So that's what we said at the top of the hour here, or at the top of the live. So that is the first thing that we talked about because it is so important. Okay. And so if you missed that, you can go back once we're done and then take a look. But yes, that is 100% what needs to be done to minimize or almost eliminate the risk of fat embolism with this procedure, is to use ultrasound imaging to make sure that you're placing that fat in that safe space, which is between the skin and the muscle.
Oh my God, yes. Finally, I find a doctor that uses ultrasound. What state? On TikTok.
Yeah, of course. So, well, we're here in Florida. So Pure Plastic Surgery, we're here in Miami, Florida. And I am actually one of the pioneers in this technique. So if you haven't we haven't met here before. I've been doing this since 2019. I've probably done more ultrasound guided BBLs than almost anyone in the entire US. Over 2,000 of these procedures on the right belt. And because I've been using the ultrasound for that imaging to make sure I'm in a safe space, I have not had an issue or a single case of fat embolism. Okay. And also because of our efforts, this now has become a law here in Florida as well. And also I believe it is now a law in New York. So these 2 states have made it mandatory that you have to use ultrasound guidance when performing a BBL. And who knows, other states may follow.
Why don't you do BBL first and then let the patient come back for a tummy tuck?
Good question. All right. So this question comes up often, and the question is typically, should I do my tummy tuck or my BBL first, right? And I always recommend do your tummy tuck first. Okay, that's my recommendation, my strong recommendation actually. Why is that? Okay, let's flip it around. Say you want to do you come in, you have some skin laxity, you have some weakness of your abdominal wall, right? These are the reasons why you would need a tummy tuck in the first place. But you say, I just want to do my BBL first. Okay, so what's going to happen with that? So we're going to do the BBL, and then you're going to end up with this skin in the front of the belly that's not going to look good. You're not going to like it at all because it's going to look lumpy, bumpy, and wavy and uneven. Okay, and also you're not going to have that flat tummy because you're still going to have your muscle separation and weakness. So you're not really going to like your tummy very much at all. Okay. And so now you're like, okay, now I need to do my tummy tuck, but guess what? Now the tummy tuck is much more challenging for the surgeon because now there's a whole bunch of scar tissue there from the prior liposuction. So now I have to get through scar tissue, the blood supply is less, the risk of skin dying or skin necrosis is higher, so the risk of wound opening and skin necrosis is now higher. There's a whole bunch of scar tissue that we need to get through. It makes the surgery more challenging and more difficult. There's more bleeding. And also, now I can't pull that skin down. I can't really stretch that skin down as much as I wanted to because of all the scar tissue underneath there. So I'm able to remove less skin overall. And so it makes for less optimal results. And you can still have some irregularities left after your tummy tuck too. So if you need to do both things, always, always, always do your tummy tuck first. Get rid of all that loose skin. Fix the muscle, the muscle separation. Tighten up those muscles. Get a nice flat belly going. Nice tight skin going. And then go for your liposculpture BBL. And at that point in time, because the belly's been fixed, even if you wanted to do some HD high definition or ab etching at that point in time, overall, even though today we're focusing on this because I think there needs to be awareness, people need to know about these common things, like common little things like seromas, is probably less than 5%. Okay, so overall complication rate is very low. It's a super safe procedure. The mortality rate is somewhere like in 1 in 20,000 or 25,000. So today in 2025, this is a very safe procedure overall.
Okay, let's keep going. Okay, let's keep going with the question.
Yeah.
Can I fill my hips without a BBL?
Can I fill the hips?
Yeah.
Without a BBL?
Yes.
Yeah. That is the good news. All right. So up until very recently, I would have said no. I think using your own fat is really the best way to do it. But say for example, you're someone who's just super skinny, you don't have a lot of fat on you, right? Or maybe you're someone who's had, this is like round 3 for you, right? And so there's no fat left because you already had liposuction like 3 times. For these particular patients, we now have a solution for the hip dip, which is off-the-shelf fat. That's right, it's called Alloclay. I'm gonna write it down here. Alloclay, okay, and Alloclay is off-the-shelf fat, which you grab it off the shelf at room temperature, and it's a structural fat that you can use to fill areas such as the hip dip, and we can do it all under local, meaning no general anesthesia. All right, and that's the best part about it. It can be done in the clinic setting, under local. You're in, you're out, minimal to no downtime.
How long of blood thinners before surgery?
No, off blood thinners.
Yeah.
Oh, okay. I was gonna say, yeah, you want to stop because it may not make you a candidate for surgery at all in an outpatient surgery setting like the one we have here. Okay. If you had prior PEs or DVTs, for the most part, you're not a candidate for surgery in the office-based outpatient surgery setting, such as the one we have here at Pure Plastic Surgery. So, I mean, if you're on any sort of blood thinner like aspirin, Lovenox, even ibuprofens, I recommend stopping all that at least a week before surgery, at least.
How long should you wear the BBL pillow for?
So you're going to use the BBL pillow during the first 6 weeks, okay? Ideally, you wouldn't be doing much sitting at all in the first 2 weeks. After that, you can start sitting with your BBL pillow up until week 6. After week 6, you can start sitting normally.
Doug, how do you prevent fibrosis?
Good question. So the short answer is you can't fully control that, okay? Some people just develop fibrosis because there's a lot of genetic components involved as well. Think of it in the same way as how some people develop keloid scars or hypertrophic scars. So fibrosis is just internal scarring. So some people are more predisposed to it. However, what can be done to try to lower that risk? Number one, the surgeon shouldn't be overly aggressive, right? You always want to leave at least 1 centimeter of fat underneath the skin there, okay, so that things can heal and you're not thinning out the skin too much, because the thinner the skin, the higher the risk of fibrosis, all right? So that's from the surgeon point of view. From the patient point of view, you have to be extremely compliant with your post-op care, meaning your massages and your compression. So you're going to need a minimum of 20 massages post-op, and of course you have to wear your compression night and day for the first 6 weeks, and then 12 hours a day for an additional 6 weeks.
What's your surgical process with the tubular breast, since it's a technically deformity?
Yeah, so when we're talking about tubular or tuberous breasts, what are we talking about? We're talking about a breast that has typically a constricted base. It has a little bit of that tube or cone shaped type appearance, and also the areola is quite large compared to the rest of the breast, okay? So you have to do a few different things, or a few different components to that surgery to correct all that. And so number one, you have to give the breast more volume with an implant, and I typically recommend a silicone implant above the muscle for these procedures, okay? Then you have to recreate the inframammary folds. Typically you gotta lower and widen the inframammary fold of the breast during the procedure. You then also have to, what they call radial scoring. You kind of have to cut through a lot of the bands, the constricting bands that are on the inside of the breast. And then last but not least, you have to do what's called an areolaplasty or donut lift, where you are reducing the size of the areola. So it does take multiple components, but it can, for the most part, it can all be done in one surgery with a huge difference, and the patients typically love their results.
Last question, Doug. In a BBL reversal, it's only liposuction of the buttocks, or can a small amount of fat also be added at the same time?
Yeah, so usually we end up doing both, right? So when we talk about a BBL reversal, it's not simply just removing fat or reducing volume. I prefer the term BBL reshaping. I think that's a better term overall, because a lot of times what happens is that people come in and they have maybe like a shelf booty, or they have too much lats and their booty still looks fairly square. And so what they want more than anything else is they want to take down the shelf. They want to go from that squarish look to that to that signature upside down heart shape. And so in order to do that, we got to remove some fat and some volume with the liposuction. But sometimes, we have to add a little bit of fat to other areas to smooth the transitions. So it's typically a combination of both things, right? We're removing fat, and then maybe we're adding a little bit of fat to create a new shape or to smooth out transitions. But overall, the overall volume of the buttock and hips will be less.
Okay. How long or how frequent do you have patients get lymphatic massages post-lipo?
So after lipo, you're going to need a minimum of 20 massages, okay? And I recommend to do them in the following way. The first 7 massages should be daily, okay? And you start as soon as the day after surgery. The next 7 massages are going to be every other day, okay? And the last 6 or 7 massages, we do 20 or 21 in total. So the last 6 or 7 massages are going to be weekly, okay? So 7 daily, 7 every other day, 7 weekly. All right? Okay, all right, everybody. Well, I hope this was incredibly helpful. Again, you know, you guys have recommendations, you have other questions, things you want me to talk about, please let us know. Otherwise, remember, you can always go to our YouTube channel. All right, so you can always go to Pure Plastic Surgery on YouTube, because we've been doing these lives for how many years now?
You have 120 episodes.
120 episodes?
Yeah.
Okay. So we've been doing this for years and years and years. There's 120 episodes there, at least, and pretty much just about any plastic surgery question that you can think of has been answered, has an answer there already. Okay. But otherwise, I look forward to seeing you all next week on Hump Day with Dr. Alex Earle. I'll see you there. Ciao.